Good evening, everyone. My name is Jeremy Shue. I'm the president of ANZAST, and I'd like to welcome everyone to tonight's ANZAST Trauma Grand Rounds. I'd like to start by acknowledging the traditional owners of the country on whose land we are individually situated and recognise the continuing connection to land, waters and community. I also want to pay my respects to elders past, present and emerging. And for our colleagues in New Zealand, nau mai, haere mai. And now I'd like to hand over to our Education Chair, Dr. Kate Mutton, to introduce the topic as well as the speakers that we have tonight. Thanks, Kate.
Thanks very much, Jeremy, and welcome everyone. Today's quite a special day in that it marks 12 months of our ANZAST Trauma Grand Rounds, which we're pretty proud of here at ANZAST, given everything that's happened over the last 12 months. So hopefully this is something that you have found useful. Certainly, trauma in the paediatric population is something we get a lot of feedback from, and those little surveys, which everyone's been so good at answering after each of our presentations, have given us a wealth of information, and paediatric trauma comes up virtually every month. So it was a no-brainer really to invite Craig McBride to organise the troops. Craig, I have had the pleasure of teaching DSTC with when I teach up in Brisbane. He is a paediatric surgeon from the Queensland Children's Hospital. He has recently completed his PhD in burns, and he has organised a great group of speakers. Rebecca Cooksey is a paediatric surgeon based in South Australia. She is co-director of the trauma service there, but is currently on leave from that position while she sets up the EMR for South Australia. And I think rightfully so said that trauma is probably an easier job. Nuala Quinn is based in Ireland, and Nuala is a emergency physician, a paediatric emergency physician who spent some time in Australia at the Royal Children's Hospital, and I think, if I'm to be corrected, Nuala will be able to correct me when she speaks elsewhere too, but certainly at the Royal Children's. James Hamill is one of our colleagues over in New Zealand. He is at the Starship Children's Hospital in Auckland and has been sort of instrumental in being involved in the paediatric aspect of trauma care in New Zealand, not just Auckland. And Warwick Teague, who is our Director of Trauma here at the Royal Children's in Melbourne, who I've also had the pleasure of teaching DSTC with, and he's taught me many, many pearls of wisdom when it comes to paediatric trauma. So what we'll do with this evening, tonight's is going to be a little bit different to what we have done in the past. Oh, I'd also, again, as per usual, just like to acknowledge the support from the College of Surgeons. Without their assistance, both in helping to get things organised beforehand, but the back end of what we do tonight, we just simply could not put these webinars on. So thank you, Virginia and Jovi and team. Tonight's is going to be a little bit different to our previous keynote addresses in that we've got a number of speakers, but we will still have a panel discussion at the end of the evening. So 4 of our speakers will speak, and certainly we'll involve James in the discussion afterwards. So if you do have questions, please send them through as the speakers are presenting. They will come up on just put them into the chat function, and it means that we can organise them and then present them to the speakers during the discussion. And so without further ado, I'm going to hand over to Craig to get things started. Thanks, Craig.
Okay, thank you. And I do apologise again for being late. So thanks for the invite, and thank you also to my colleagues who've shared the load. What we've decided to do is and concentrate on some of the questions that you had that have been asked, and also to each of the 4 speakers to take a particular area of paediatric trauma. So my name's Craig McBride. I'm a paediatric surgeon. I'm a researcher. I've just finished my PhD in paediatric burns, and I'm an ethics wannabe in that I'm on the Children's Health Queensland Human Research Ethics Committee and also the Clinical Ethics Consulting Service. I'm not an adult surgeon. Next slide, please. But I am a frustrated trauma surgeon, and I'm a frustrated trauma surgeon because the surgery for trauma in pediatrics is actually pretty uncommon. And my hope tonight is that by combining the experience of myself and my colleagues that collectively we may approximate the experience of some people in the audience, because I'm pretty sure that individually we don't. And so we spend our lives training to perform operations that frankly we hope never to have to do. And I'm also a frustrated trauma surgeon, because most of what we try to achieve with trauma in pediatrics is to prevent it from happening in the first place. And with recent exceptions, we haven't made particularly large gains in that space, although Warwick may have something to say about that shortly. I wanted to give you a brief flavour of paediatric trauma as we see it in the Children's Hospital. Next slide, please, and then the one after immediately. We see about 850 children a year at Queensland Children's Hospital that are admitted for more than 24 hours after a traumatic injury. About 11 to 15% of them will have an ISS of greater than 12. And penetrating trauma in childhood makes up a very small percentage. It's approximately only 2.5% of what we see. And of that 2.5%, most are actually penetrating eye injuries rather than penetrating injuries per se. So that's vastly different from what we would see, for example, with our North American colleagues, who are seeing, sadly, thousands of children who are the victims of penetrating trauma, most commonly gunshot wounds. In our setting, falls are by far the most common traumatic injury that we see, with lacerations, burns and scalds being the next most common. The vehicular accidents are probably the next largest group collectively. And in Queensland, animals continue to be a source of trauma for children, either children falling off animals like a horse, or children getting too close to animals and getting bitten. When does trauma occur in childhood? The data on the next slide are from the Trauma and Research Network in the UK. And on that slide, the orange line represents weekdays and the green one weekends. And you can see that most trauma in children occurs during daylight hours. And so if you're not particularly interested in treating trauma in children, if that's something that you'd prefer to avoid, then the way to avoid that is to volunteer to do more night shifts. Next slide, thank you. And keep rolling through. So between midnight and 7 o'clock, there's almost no trauma in children. And then from 7 o'clock through to the late morning, early afternoon, there's a small blip, but not particularly much. And most children that get injured are injured in the afternoon and into the early evening. I'd like to hand over to my colleague, Warwick Teague, to discuss trauma that involves the head and spine in children.
Thanks very much, Craig. Just as Warwick's taking control of the presentation. Again, I just encourage everyone to put their questions in the chat. Thanks, Warwick.
Pleasure. Thanks, Craig. Thanks, everyone. So I want to talk about pediatric head and spine trauma, and I'm not a neurosurgeon, and I'm not an orthopedic surgeon with an interest in spinal trauma, but probably neither are you. So that's a good thing. And these are the kinds of pearls that I think are worth handing down. But I do work in a fairly large pediatric major trauma centre, and I do work within a mature trauma system. So it's really from within that context that I'm reaching out to you today. So I want to spend the next few minutes talking about head injury in kids, spine injury in kids, and then I want to look at different ways that we can apply this same knowledge to injury prevention, which focus particularly on seat restraint or car restraints for children. If you have children who sit in cars, I really want to reach out to you as parents and carers rather than clinicians in that moment. So what is it about kids and their heads? Well, basically, kids have these massive melons of heads. They're enormous compared to the size of the child. So here you see a child at very early age, and And even earlier than this in the child's life, that the head may have been almost a third the total length of the body. And as the child grows, the relative proportion of the head to the total body height becomes less. And what is this doing for children? It's meaning that they get they have a very large head, so they're easy to knock, easy to injure in whiplash or deceleration, acceleration injuries. And should they bleed, they can lose a very large amount of blood very quickly. And the size and the propensity to trauma, but also the blood loss, is a very sad reason that the infamous claim to fame for head injury in children is it's the #1 cause of trauma-related death within our trauma systems or trauma systems like it. So we don't have lots of gun trauma, for example, and that is an important aspect. So most series would consider neurotrauma to be the #1 cause of traumatic death in children. And there's another sad claim to fame that head injury has in children, and that is that it is grossly overrepresented within non-accidental trauma. And in our series at the Royal Children's Hospital, if we look at our neurotrauma deaths, we see that approximately half of those occur in the context, even if only recognised in retrospect, of neurotrauma. And if we look at those children who sustain traumatic brain injury, who are less than 1 in whom that injury is not witnessed by someone outside of the family unit, about 1/5 of those have non-accidental trauma. So this is a very serious and significant issue for children. A tricky part of assessing a child is assessing their conscious state. And so many of us will be aware of the Glasgow Coma Score, but this applies to children in different ways, and it can be quite hard to apply correctly, because what does incomprehensible noises mean if it's a 2-year-old? Maybe that's what they're used to doing. And so many people, many systems have adopted AVPU or AVPU as an accurate and pragmatic, clinically relevant way of assessing conscious state in children, and for that matter in adults. Now, it doesn't replace Glasgow Coma Score, and so if you are particularly interested in the GCS, if you were a neurosurgeon and if you had need to know the Glasgow Coma Score, then someone should be able to derive that for you. But if you want to make good pragmatic clinical decisions, including the decision as to whether the child needs their airway protected with intubation, then the AVPU scale is something that we can recommend for you. This has been now very widely adopted, and I've highlighted here a paper which looked at the relationship between AVPU and Glasgow Coma Score, and highlights that those with an A or a V are reliably have a GCS more than 8. So just recommend that to you. The other thing that people ask a lot about is what imaging should be done for children, and how should we make decisions around their management. It's important to understand that it's that early involvement and early recognition of significant head trauma is very important for the outcome. So I'd encourage you to involve early those that are most expert in your system in the management of neurotrauma, which for many of us will be a neurosurgical service. They may need to make early decisions about whether this is an intracranial pressure that needs to be monitored, or whether it needs to in fact be a raised intracranial pressure needing decompression. And these are the groups that are going to take the lead in the traumatic brain injury management, including the appropriate assessment for and management of post-traumatic amnesia. But specifically who gets a CT? Who should be imaged with a CT? It's a vexing problem, and I want to recommend to you this Australasian pediatric head injury rules trial at first, which was done by a whole lot of centres with it throughout Australasia. I think all of which are represented by the people talking to you today, and this study looked at the outcomes of CT scans and looked at different rules that can be applied. So we have rules well known to pediatric practitioners within Australasia and North America, rules well known to the Canadian colleagues and UK colleagues. And they looked at things, for example, in this table, which is taken from the paper in the Lancet, at if you were negative on your rules, how many of those people actually had a head injury of note? And you can see that there was a varying performance of each rule. And I would recommend this paper for you if you're someone who would like to know more about when to order a CT in head injury. This is an important paper. Now, how do I make sense of all of this? So I make sense of it by saying all of these rules, as stated in the paper, have a degree of high sensitivity and high specificity. But if sensitivity, the higher you get, the lower your false negative rate, then the rule with the most superior sensitivity is the rule that's going to help you to say no to doing a CT of the head. So if you're someone whose natural reaction is to investigate early and to do many CTs, and you're thinking, how would I find a good way to say no to doing a CT, then the PCAN is the rule that has the most superior sensitivity in this setting. And so that's good for saying no. But if you're someone who is so reticent to say no that you're looking for a rule that would embolden you to say yes, and specificity, the higher your specificity, the lower your false positive rates, then Chalice and Catch both have superior specificity over PCAN. So that's the kind of rule that you might adopt, knowing your institutional personal tendency to under-investigate head injury. So each of these rules will have utility depending on where you fit into it. So use PCAN to say no, Chalice and Catch to say yes, and apply that to your local thing rather than thinking that one rule is going to be the best for everyone. So what about spinal trauma? We don't have to go much further down from the head to reach the spine, but we shouldn't think of the spine as just cervical spine. So often in our language, we talk about cervical spine, C-spine, and we're forgetting that, in fact, of course, the spine has cervical, thoracic, lumbar, and yes, maybe sacral, but not so important in trauma, perhaps. Now, the thing about cervical, sorry, I've done it myself. The thing about spinal assessment and management in children is it's very common to need to assess these because children arrive who are significantly injured and they need an assessment. But it's rather uncommon to find an injury. And it's certainly much less common than in the adult trauma cohort. So here we have a 16-year series from the Royal Children's Hospital. We're getting about 5 spinal cord injuries a year at different levels, and we're getting about 34 spinal cord traumas without spinal cord injury, spinal traumas without spinal cord injury a year, again at different levels. So how do we bring our best to assess what is an uncommon situation in children who can be difficult to assess at the best of times? And I think it's important just here to highlight some of the similarities with adults and some of the differences. So in similar to adults, the language and the sentiment here is about spine motion restriction. We've abandoned this idea of immobilization because that is not possible, nor necessarily what we ever achieved. And there's been increasing adoption, including within the hospital that I work in, and I know that many of others are well ahead of this, including in Queensland, the adoption of soft collars as a key adjunct towards spine motion restriction. If you're interested in that, then tonight is not the night to hammer that home, but it is a really interesting thing. And we need to make sure, just as in the adult, that we assess the cervical, the thoracic, and the lumbar spine. Now, what are the key differences with adults? Well, there's this massive melon that they've got in the younger age groups, and that head is going to tip forward, confounding our efforts to maintain a neutral position in the less than 8-year-olds. So in the less than 8-year-olds, it's important to elevate the thorax, and I've got some pictures here just showing, and I thank my colleague Sanderpan from New South Wales for these images. So you see here, this is Sanderpan's son. Thanks, Sanderpan. The relatively large occiput is tipping the head and confounding the neutral position. They've used something as simple as a roll of towels here behind to elevate the thorax, bringing the thorax up off the flat surface I don't think there's intention for using spinal boards, by the way. This is just for the purpose of this picture. And now that's brought the spine into a neutral position. So that's a key thing. We recommend it for the under 8-year-olds. And if you want to know more about that, here's a resource that you could look at, or I'm sure that there are other resources known to you locally. What about other differences? Well, mechanisms of injury can be very different. We'll look at that in a moment. And our anatomy of the child is very different, particularly because of the laxity of the ligamentous structures. And so the patterns of injury are very different. And remembering, of course, our massive head that's sitting on top of that spine, which can be very different. So the imaging rules for the cervical spine may not apply because they are focusing on adults, whereas look at all these differences, they may be important. So what about mechanism? Well, here are some mechanisms from the same series of spinal traumas that we saw over 16 years. And we see that motor vehicle crash occupants are an important group, but so are those injured during recreation, whether it's transport, on sporting, those who are on dangerous implements such as quad bikes, horses, for example, and let us not forget non-accidental trauma. So we've here a real range of mechanisms. Some of these are a little bit unique, not unique, but peculiar to the pediatric age group. But what else can we learn from these mechanisms? Well, we have to look here also at the levels for children. And this is again the same cohort. And we've identified here all the different levels. And if you are used to seeing levels of injury, of spinal injury, something is jumping out here at you. And it's jumping out, look at this. This is outrageous. Look at all these high cervical injuries. You're not used to seeing these in adults. This is something very unusual. And look at the number of children under the age of 5 years or younger at these very, very high cervical injuries. Why is that? Well, it's because of things like the very, very large head. If you have the moment of force being delivered over this very, very large head through acceleration and deceleration injuries, particularly, for example, motor vehicle crash occupants, then that contributes to these very high rates of high cervical. Again, the shaken baby is another baby in whom these high cervical injuries can occur. And so if we look at mechanism of those that are transport related, we see clearly an overrepresentation of transport related injuries in these high cervical injuries in children. But there's another group which I want to highlight, and these are the lower thoracic. We're going to come back to this in a moment, but these are classic seatbelt injuries. This is the classic chance fracture in the low thoracic upper lumbar. And again, look at the overrepresentation of transport-related injuries. These are these catastrophic deceleration, acceleration injuries where the abdomen is struck by the poorly applied seatbelt. So just bringing this together, we've got differences between adults and we've got similarities and differences. And when we look at the various rules, and I've just picked out here the Canadian C-spine rules and the Nexus spine rules, because at least in recent times, these have been very popular. But I would like to say these are really MA 15 plus. I think we have to be careful about applying these to children. That doesn't mean they have no place, but as soon as they start saying things like age over 65, you're thinking, oh, I'm probably reading the wrong guideline here. I'm grateful for the people who are putting all sorts of different prospective guidelines in the chat. I think that's really great because I'm just sharing the things from me locally, but you must have great resources with you as well. So how do we approach cervical, how do we approach spine assessment in the child? And this is our approach. We ask key questions. Is the child awake and accessible? Are there overt features of spinal trauma? Are there other features of spinal trauma? And are there high-risk mechanisms that have to be entertained? And the intention here is not to walk through the algorithm, because this is our local algorithm and you'll have yours, and it's much more important that you're familiar with yours. But you can see how these key considerations overlap and dovetail as we work our way through in an orderly process. This orderly process will bring people to assessment which prioritizes in the accessible patient those overt features which quickly allow early referral and involvement of specialty areas. It also cautions us not to overlook other features which, if we only go for the overt features, we're going to miss patients of importance. And even if those are absent, are there any high-risk features? And if they are present, then we still need to be making further assessments, including imaging. But it also provides us with a structured way in which the accessible patient can be fully assessed and safety and confidence gained even without imaging. Of course, there's also the child who's not accessible, and so that's very hard because we can't look for these overt and other features. We have to really rely upon high-risk mechanisms, and so that's why it's good to define high-risk mechanisms, and we've done that for us locally, and you should do that where you work too. And if you find any of these resources useful, you can go to the Royal Children's Hospital, and these are guidelines which have 3 states of acceptance behind it within Victoria, New South Wales, and Queensland. So in cervical spine imaging, I would ask you to request gently. You can very, very easily allow your brain to become slackened and pan scan the head and neck without really thinking through whether the neck needs that radiation. Remembering that cervical spine injuries, if we think about the neck, they are uncommon in children, and spine injuries in general as well. Consider the use of acute MRIs, which may in fact be preferable over a CT, and that's a decision that you would make with your expert specialists such as neurosurgeons or orthopedic surgeons with an interest in spinal trauma, particularly if it's cord injury you're looking for, because the CT will have little, if any, relevance in that setting. And you may well have time to wait, and so waiting for the dust to settle on the next day for a reassessment may well be in your interest. I think we should remember that unlike some of the discussions around abdominal imaging, CT spine is not the gold standard in children. So we want to be providing good assessments, provide support from a collar, understanding their limitations and what they are and aren't achieving, understanding the limitations, even the word clearance, and knowing how to use our MRIs. And again, this is where our neurosurgeons and orthopedic surgeons can guide us. So do you remember this massive melon that this child had when they were young? We need to apply that now to the good and bad fits of car restraints. So this is the reason why we have children who are rearward facing in a car seat. And this is why it's so important that children are not moved too quickly from a rearward facing to a forward facing car seat. And I emphasize that, and I'd be interested to hear from James later, but in Australia, we have laws that permit early movement of children from being rearward facing to forward facing. And those laws do not keep match with best practice recommended for the safest carriage of children. So in the event of a crash, this child's head's going to go first back into the car seat, absorbing the majority of the force in the spine protecting situation, and only secondarily move forward. However, if the child is brought into a forward-facing car seat for the same moment of crash, the head is going to flex grotesquely down and only stop because the chin and nose strike the chest. And that's the only thing that stops it from turning off altogether. And so only in that situation, this situation, the child can get a very significant high cervical injury. And we've seen the devastating reality of that in the figures that I've shown you beforehand. Kids who are not yet 145 centimetres need to be brought into a higher position because if we don't, and if they are put too quickly into a car seat with just an adult car seat, they have their head and neck in danger from the sash belt crossing their neck, and their abdomen in danger from the lap belt riding up high. And I'm sure that I'm getting lots of texts to say that hurry up. So I'm just going to say to you that you should, if you carry children in car seats, you should think carefully about the height difference between a 7-year-old, where you can legally carry a child without a booster seat in children in Australia, and an 11-year-old. And I would implore you to put your not yet 145 centimetre children back into a booster and to share that truth and good advice with all your friends. Okay, I'm going to stop it there because I think that I'm well and truly over time.
Thank you
Thanks.
very much, Warwick. I think we've got Norla next, who's going to continue.
Let me just introduce Norla. Norla was a trauma fellow with us at the Royal Children's Hospital and is a complete legend. That's all you need to know about Norla.
Okay, so my name is Nuala Quinn. I work in Dublin Children's Hospital. I'm a consultant in paediatric emergency medicine, and I actually, Kate, you're right, I worked in RCH. I completed a fellowship in paediatric emergency medicine, and then I worked as a trauma fellow for a year under the stewardship of Warwick. I also love POCUS, and I've been recently appointed as the National Lead for Pediatric Trauma, with the endeavour to start building and creating Ireland's first paediatric trauma system. Next slide, please. So we know, I suppose, that traumatic injury is the leading cause of death in children worldwide. It causes huge amounts of hospitalisation and long-term disability. And TBI is reported as the leading cause of paediatric trauma death in most series that you look at and read. But thoracic trauma is also a leading contributor to this burden. And Craig earlier mentioned TARN. The majority of trauma deaths occur in children with severe isolated TBI, isolated chest injury, or a combination of both. And we had a look at a 10-year review of presentations to RCH, which showed that children with severe thoracic trauma were 10 times more likely to die from their injuries. So the emergency management of life-threatening thoracic trauma is really, really important in the paediatric trauma resuscitation room. Tension pneumothorax, massive hemothorax, and traumatic cardiac arrest, or they're traumatic life threats. They require emergency pleural decompression, and thoracotomy and chest drain are core trauma skills. And next slide, please. So for us in paediatrics, this is particularly problematic. Within paediatrics itself, there is definitely a general unease to perform invasive or bloody procedures in the specialty itself. But I mean, we seem to be very comfortable with performing lumbar puncture in a neonate 2 or 3 times without sedation. That's widely accepted, whereas thoracostomy and chest drain insertion under ketamine isn't. So there definitely is a widespread change of mindset needed. The trauma in itself is uncommon. Our data would show that it's between 1 to 2% of all trauma within Ireland itself. So there definitely is a lack of familiarity. And I suppose, in addition to paediatrics as a specialty, I think it would be widely accepted that we do have a problem with dogma. Now, in our centre, we've all but removed needle thoracentesis in trauma, and we're creating a credentialing programme for traumatic procedures. But you know, generally in paediatrics, needles still remain despite this documented 60% failure rate. And the 60% failure rate in children is exactly the same for that in adults. So inadequate catheter length, the catheter is becoming occluded, inability to penetrate the pleura, subcutaneous bullae, and they're also really, really easily dislodged because most of them that go in are actually yellow catheters. And I've had patients come in traumatic cardiac arrest who on their pre-hospital transfer have had ROSC obtained each time a needle has been sited and then loss of output. Then the needle was repeated and they only really got definitive ROSC when thoracostomy was performed in the emergency department. Next slide. And can you click again, please? Thank you, that's great. So in a patient in traumatic cardiac arrest, obviously we'll automatically do bilateral thoracostomies, either with finger sweep or in smaller children with a mosquito or artery forceps. But in injured children who are not in traumatic cardiac arrest, often the pneumothorax and the hemothorax are picked up in the primary survey, and POCUS enthusiasts like myself and the majority of the adult emergency physicians are absolutely amazing at POCUS. But we can do a quick point of care on the lungs using a linear low frequency probe. Now on the left side of the screen you can see, sorry, would you just go back the ultrasound. Thank you. So on the left side of the screen, we can see this black vertical shadowing, which is the rib space, and in between each space we can see a white horizontal line, and that's the pleura. So the video on the left shows the typical lung slide of the pleura with normal movement, whereas in the cine of the right of the screen you can see that the pleura is at a standstill, and that indicates loss of lung slide and therefore a pneumothorax. Next slide, please. So just back a slide. Thank you. So if the child remains clinically stable, then chest reinsertion can occur, but it's not uncommon that rapid deterioration and therefore life-saving manoeuvres are actually needed. And in this case, then emergency pleural decompression by thoracotomy and sweep by either finger or forceps is then the required procedure. And in both of these situations, and in those of traumatic cardiac arrest, the thoracotomy is performed, followed by chest reinsertion at a time appropriate for the child's clinical priorities. But pediatric trauma resus is pressurized, it's hectic, and it's time constrained, and there's a huge cognitive burden on the team leader and also on the procedure doctors to perform these procedures. And so when we were at RCH, anecdotally, we were noticing that the drains were being inserted too low, they were being inserted too far in, and the time taken to locate the safe zone was prolonged. And also within the emergency department itself, performing clinicians were reporting that the procedure is extremely stressful. Next slide, please. So Warwick Teague came up with this concept of the rule of fours, and it's an adjunct to ease the cognitive and practical challenges of thoracotomy or chest reinsertion in injured children. It's extremely popular on this side of the world. It's an aid memoir to ensure the important therapeutic goals of pleural decompression are met through 4 steps. So the first step is 4 steps in a good plan. Secondly, the 4th or the 5th intercostal space is the basis for siting a good hole, so the safe space. Thirdly, 4 times an uncuffed ETT to select a good tube. And lastly, the 4 centimetre mark to make a good stop. And so what we want to do is ensure that the tube is in far enough, but not too far. Next slide, please. So when we're asked about the differences between adults and pediatric trauma, one of the obvious differences is the size of the patient, as Warwick has just alluded to, with their heads. I've done thoracostomies in 14-month-old children or infants run over at low speed, and you won't be able to insert your finger in the small children. So this is part of the rule of fours, or this part of the rule of fours is particularly helpful. You can see in the table. So for age 4 or less, perform your sweep with a mosquito. Between the ages of 5 to 2, then an artery forcep, and over 12. And you know, even around that kind of 10, 11, 12 age group, if they are physically big, then you can use your finger to do the pleural sweep itself. Now, the next video, it shows this concept well, where you can see the proceduralist actually feeling for the rib spaces, which obviously won't fit even my small fingers, and consent was given for this. We're a bit stuck there, but so you can hear a loud hiss of air, and then similar to adults as well, then once the air and blood have been released and the life thread has been managed, then the chest drain can be inserted. But that's one of the things that we would get asked a lot, is the difference between the small children and the older children in the pleural sweep. And what you kind of can see at the end of that video then is that the pleural sweep was done with the artery forcep. And that child was actually 9 years old. It wasn't a 6-year-old. But you can see at the start of the video, I'm trying to feel the rib spaces, and I clearly will not be able to get my finger in through there. So a common pitfall and a danger of chest drain insertion in trauma is to advance the drain too far in. Next slide, please. So if we look at the chest x-ray on the left side of the screen where the drain has been sighted too low and is too far in, and you can actually see the tip denoted by the cursor there. A chest drain that's advanced too far can cause significant iatrogenic trauma, and so this can be avoided by knowing when to make a good stop to advancing the drain. So to inform this stop again, the magic number is 4. So advance the tube to the 4 centimeter marking so that the last drain side hole is 4 centimeters inside the chest cavity, and that will ensure that your drain is in far enough but not too far. And the chest drain on the other side, on the right side of your screen, is one that I cited using the rule of 4s technique. Next slide, please. And using the right instruments, I suppose, and sighting the drain correctly, it means nothing if it's not going to hit the safe zone, which we identify as the 4th to the 6th intercostal space. Difficulties in identifying a safe site for thoracotomy and chest drain insertion are really well recognised within adults and within paediatrics. And whilst a triangle of safety for insertion can be defined by the anatomical landmarks that you can see in this slide, the muscular boundaries can be really difficult to recall, especially under the cognitive demands of trauma resuscitation. And there are several studies that report widespread difficulties in recalling or applying the anatomical boundaries, with more than 40 up to 45% of simulated or actual chest drain insertions being outside the triangle of safety. Next slide. This is a paper that came out of the Alfred a couple of years ago, and it sought to identify a new biometric approach using the patient's proportional skeletal upper limb anatomy to allow correct identification of the chest wall skin site for chest drain insertion. A length of tracheostomy tape that you can see in the image was passed from the tip of the acromion to the tip of the olecranon and folded in half to determine the midpoint. Next slide, please. They used 30 healthy volunteers, 4 very experienced consultant trauma physicians with a total of 92 years experience, and they independently performed the management. It was repeated, blinded, markers were removed, and they reported 100% of measurements were in that safe zone, and 86% of those were in the intercostal space. Next slide, please. So that led us to our MAP study. And so in RCH, and 3 other centres, namely Sandringham at the Alfred, Sunshine Hospital, and then the hospital where I work in Dublin, we hypothesised that the same mid-arm point technique, that it would actually accurately site emergency pleural decompression within the safe zone for injured children. And so, if so, then the MAP technique would be a very important adjunct for clinicians seeking to deliver safe and effective paediatric trauma care under those cognitive and time pressures that I talked about of trauma resuscitation. So children aged 0 to 18 attending any one of the 4 participating EDs that I named were prospectively recruited. We performed the mid-arm point technique, and chest wall skin was marked on both sides of the mid-arm point level. We didn't perform any pleural decompression. This was on children who were having chest x-rays performed for other medical or surgical needs. And at the skin site level, we placed radio-opaque markers over that mapped determined skin marker, and the corresponding intercostal space was then reported using a chest x-ray. Next slide, please. You can see here the radio-opaque markers on either side of the chest wall. We recruited 392 children and 712 markers were cited, and it's enabled us to devise a new rule for identifying the safe zone for emergency pleural decompression in children, but it is unpublished and it's only been submitted this month. Next slide, please. I'm just going to do a very quick slide on paediatric emergency resuscitative thoracotomy. Within paediatric trauma, penetrating chest trauma is extremely rare. That would be kind of evident in the data worldwide and anecdotally in the centres where I've worked. But there's been a historic reticence, as I've said earlier, to do invasive procedures in children in the emergency department. So doing an emergency resuscitative thoracotomy in a child is it's a really, really big deal. And the stakeholder engagement that would be needed to do something, or that is needed to do something like this in Ireland in particular, is absolutely massive, because we have the merging of 3 children's hospitals in Dublin. We're completely reconfiguring how we provide paediatric care in Ireland. We're building a new children's hospital to open in April 2024, and it will be Ireland's only paediatric major trauma centre. And we're also developing a national paediatric trauma system. So the stakeholder engagement for these things is huge. Now, that said, we have had a recent increase in teenage stabbings in Dublin. So the impetus is there to just get on and get this guideline done. And recent publications on traumatic cardiac arrest it's almost now, it's a Delphi consensus study, but within paediatrics, it's a really important paper written by Vassallo and the Perucchi team. And these studies have really helped. Next slide, please. And so this is the draft traumatic cardiac arrest algorithm for my hospital in Dublin, and the focus is on the life-saving bundle of interventions. So the introduction of emergency resuscitative thoracotomy and deprioritization of chest compressions, defibrillation, adrenaline and saline, which you can see they aren't even mentioned in the algorithm, but they are addressed in the accompanying text. So this isn't a big deal for the adult trauma world, but it is a pretty seismic shift for paediatrics and a very positive step forward. Next slide, please. And I just, before I finish, like to draw your attention to 2 video resources that are particularly helpful for paediatric chest trauma. So the first is a detailed video from Warwick Teague at the Royal Children's Hospital on how to perform thoracotomy in children. It addresses everything from preparation right through to suturing the chest drain in. It's excellent. And secondly, we made a roadside to resus video from our team in Dublin, documenting or showing the patient journey from a child getting hit and run over, the pre-hospital care through to the trauma reception and resuscitation in ED. And last slide, please. This is our child actor showing that he's safe and well. And thanks very much for your attention.
Thanks very much, Nuala. Thank you. That was a great presentation. Just as we're getting our final speaker ready to go, who is going to be Rebecca Cooksey. I think Rebecca is coming up online.
I'm here, yep. Thanks, Kate. Terrific. So I just wanted to start by saying thanks so much for being invited to speak at this event, particularly to Craig. I'm just a regular humble paediatric surgeon. I am the co-director of trauma in my hospital in South Australia, along with an excellent academic and researching orthopaedic surgeon, but I myself am not a researcher. I am a workaday surgeon. So I'm going to give you my perspective on solid visceral injury in particular. So I'll get you to advance the slide. Thanks, Jodie. And again. Excuse me. So we've spoken a little bit already about what the influence of trauma is. Just to really lay it out, it is the leading cause of death in childhood. It's the major cause of disability in childhood as well, particularly in developed countries. So much of our evidence is derived from adult literature, but there is a reciprocity in our care for children who've been traumatically injured. Some of our practices, particularly in the setting of splenic injury, have informed adults' care tremendously. I'm just going to, inability to advance my own slides has a small impact. So in South Australia, in 2016-17 financial year, there were 44,000 presentations to public hospitals. There were nearly 6,000 admissions in under 18-year-olds in trauma. Now that represents a huge burden to the healthcare system. So what is unique about children? Excuse me. They're so different in the mechanisms of injuries that we see, that multi-trauma is generally the rule because children are smaller, that adult protection systems, as Warwick has already spoken of, do tend to be designed for adults. Seatbelts, ill-fitting, as we've already seen, or worn correctly, can contribute tremendously. The smaller size, meaning the force per unit area, is more significant. Thin skin, little subcutaneous fat, greater elasticity of their tissues. And all this means that internal organ injury is more likely without skeletal injury. So our solid visceral injury is much more likely, particularly in younger children with those elastic protective systems. Their smaller thoracic cage and abdominal compartment means that their organs are relatively more exposed. Your liver, your spleen, for example, much more exposed. But I won't labour this on. I've already been given the hurry up from Craig. So Jodie, I'll ask you to move to the next slide. So just as a summary of what I will cover, I'm going to talk about what our solid visceral injury evolution of care is in paediatric with a focus on splenic injury. I'll touch briefly on embolization in paediatrics and some of the difficulties, and then talk very briefly about minimally invasive surgery in paediatrics. Thanks, Jodie. So the spleen in particular, I'm going to focus on, as I said, is an immunological wonder, but to many it's a superfluous organ. So what is the incidence of splenectomy? Well, in US studies currently, it's just over 4% in paediatric trauma. That number is continuing to decline. And the impact of splenectomy is the main reason why there's been a driver to reduce traumatic splenectomy. So how bad is OPSI? We're all familiar with that term, overwhelming post-splenectomy infection. It really has a massive impact on paediatric population for a number of reasons. And one is that the duration of time that that individual lives without their spleen. And also the immunological system of a child is otherwise relatively immature. And the incidence of severe infection in the splenectomized patient is 6-fold higher than the average population. And that severe infection does have a significant ongoing impact to their care. And that's in addition to that burden of the immunisation regimes and the preventative antibiotics that are required. Thanks, Jodie. So this is an image of a child with a handlebar injury. Now, when I come across a child like this in my hospital who's presented with a handlebar injury, my heart sinks, and particularly in this location. It's such a small abrasion, but it belies such a significant underlying injury. And I'm sure all of the paediatric surgeon or people who care for children in the audience who look at this image will have a similar reaction. I'll get you to roll on to the next slide, please. Just by way of how much of an impact the care for children has influenced our splenectomized patients over time. This is a really interesting article that comes from a paper published 2 years ago. It's called "To Save a Child's Spleen, 50 Years from Toronto to Atomic." Now, Atomic is a research group that produces some great papers. I'm sure many of you may well have read these. And in particular, this paper looked at how care for the injured child with splenic trauma has changed over time. You can see clearly that there is a reduction in length of stay over the 5 decades. And in particular, on this slide, it has the impact of various research publications and guidelines on how we do care for children, starting with the American Pediatric Society, Surgical Association, guidelines, which come in first in the mid-90s, which had a sharp decline in the length of stay for children who have splenic injury. And those guidelines really were around, can we use the grade of splenic injury to inform how long a child needs to be observed in an intensive care situation? How long do they need to stay in hospital for? And then what their follow-up immobilisation or avoidance of high impact sports, for example, should be. And with some great guidance around that, you can see a huge impact, but it doesn't end there. Further publications also show that we need to look more at the hemodynamic stability and pain that a child is in, rather than using simply the grade of injury. So that's where just after 2000, the 2000s, throughout the grade book guidelines came. And the most recent one, the Atomic guidelines, published a couple of years ago, have made a modest impact on reduction in length of stay. I'll get you to move on. Thanks, Jodie. Next slide. Sorry, I'll get you to just move back one slide there. Thank you. So this is one of those key publications where the non-operative management of blunt liver and spleen injury in children was the guidelines were published using GRADE, which you're all familiar with, I'm sure, the grading, recommendation, assessment and development and evaluations. A really structured way in order to produce consensus statements and guidelines on complex injuries. And this is really what had a huge impact on reduction of length of stay, and which guides care in most hospitals throughout Australasia currently, or an adaptation thereof. It's worth noting that there are some situations where the reduction in length of stay is not possible due to modifying factors, such as if we have a contrast blush on CT scan or bicycle handlebar injuries, for example. They're not candidates for early discharge in the same way. And in addition to that, re-imaging is not well defined, generally not used in paediatrics. However, in high-grade injuries in the spleen or in the liver, particularly where they're at the hilum, they are in a higher risk category for developing pseudoaneurysms, and so are more likely to require repeat imaging. I'll get you to move on. Thanks, Jodie. This is a complex slide, and I'm not asking you to look at the detail in this slide, but just that this is the algorithm which was published. And what I want you to look at is just down the right-hand screen, where it goes through the unstable patient that's not responding to fluid resuscitation, who continues to have hypotension. It is such a small pathway down that right-hand side, and you can see so many efforts towards the left of screen throughout the rest of it, but efforts and mechanisms which are taken in order to encourage non-operative management of splenic injury. I'll just get you to roll on to the next slide, Jodie, because this is a much simpler portrayal from the American Pediatric Surgical Association. This is the most recent recommendations from them, which are implemented and followed in my hospital, that going through clearly what admission criteria are suggested, procedures and interventions. And I really like the self-referential abbreviation in forcing the set free in the APSA guidelines. When to let the children out, when to mobilise, when to return to normal care and aftercare. I won't labour that through. As I said, I already want to give us some more time to discuss in our forum. So let's roll on to the next slide, Jodie, where splenectomy indications in this publication from the PSI are fairly obvious to all of us who are involved in trauma care. That blood transfusion within 4 hours of a patient's arrival into hospital or a high-grade splenic injury are the indications for splenectomy. That's fairly logical. Roll on to the next slide. Just for a little bit of light relief, a CT scan with a splenic injury, we can roll on to the next slide. Now, Warwick had mentioned briefly using algorithms to inform our use of CT of the head in brain injury. Now, really, we are still very much in a situation where CT for paediatric abdominal trauma is the gold standard. And while Craig will touch briefly on ALARA principles, I think still after this, if we have time, it is really important to understand that there are some criteria in which it is safe not to CT scan a child in the setting of blunt injury. And in particular, children who have trauma where it's not motorised, they have a normal GCS and normal hemodynamic markers, then a CT scan is really not indicated, and serial examination is worthwhile. I just wanted to put that out there because we always do think about immediately CT scanning the abdomen, and rightly so, and we should always do that in the setting of any evidence of peritonitis or instability, but there is a role for serial examination in paediatric abdominal trauma. Let's roll on to the next slide, Jodie. So embolization, while it is a tremendous mainstay of care in adult trauma, as you would all well know, there are some really significant difficulties in the use of embolization in paediatric trauma. This is dear to my heart currently as we're getting ready to undergo trauma verification for the South Australian hospitals. And as a level 1 trauma centre, then reliable and easy access to embolization is essential. However, we do not have an in-house interventional radiologist at my children's hospital, even though one is very willing and very capable to come and intervene when required. Needing to have a dedicated suite, needing to have specialised equipment that is appropriate for paediatric age ranges, and that does involve a broad range of sizes and complexities of children, is particularly difficult. There is some reduction in the size of angiocatheters and balloons, which is coming into common availability due to vascular surgeons advancing below knee intravascular interventions. But it's still a long way off from being routinely stocked in all major paediatric trauma centres, and then having, as I say, the expertise and the other equipment available in order to do this. But it needs to be a part of the algorithm regardless. And this study has shown that angioembolization is over 90% effective in treating solid organ injuries in paediatric populations. There is also a tremendous role in pelvic trauma. And for that reason, in adolescents with pelvic trauma who do have a higher incidence of requiring embolization in South Australia, they are diverted towards the major trauma centres for adults, just as an indication of how important that really is. The typical suite of complications that we see with embolization, pseudoaneurysms, etc., they're common to paediatrics and in adults, and are not a reason to change that. Jodie, I'll get you to move to the next slide, thank you. So, and next slide again. In the interest of time, I'll move forward to minimal access surgery in paediatric trauma. I like to think of it as an evolution of DPL, but diagnostic peritoneal laparoscopy. It's important to understand, though, that laparoscopy now goes beyond just diagnosis and is readily used for treatment and intervention as well. Yes, it does need to be limited towards hemodynamically stable patients. But in centres who have trauma expertise and paediatric minimal access surgeons, it seems like a logical dovetailing. In this publication from Nashville, there was a comparison of laparoscopy to laparotomy in the paediatric population of a mixed trauma hospital, but focusing on the paediatric trauma presentations. It was noted that laparoscopy for trauma was more commonly employed in younger female with lower severity injuries and more commonly with blunt injuries, which is more a reflection, I suspect, of the severity of the trauma rather than necessarily those individuals. But just to say, it can produce fewer complications overall, even though it is in a population where there are more well patients, if you like. There is an increased time from presentation to intervention procedure, interestingly, in which case we again can see that it reflects a population who have less severe injuries or perhaps a less breadth of injuries. Jade, I'll get you to roll on to the next slide. Thank you. So what are the considerations in minimal access surgery? Well, it's really good for diagnostic, particularly in penetrating injury. I have found in particular using laparoscopy in blunt trauma with a suspected bowel injury or to assess the severity of a bowel injury can be tremendously useful. And then with consideration to conversion for open surgery if a resection is required. There is potentially a role for assessing liver injury with washing the peritoneal cavity out and assessing for bile leak. And certainly a role for diagnosing and potentially subsequently treating traumatic hernias. So what are the concerns? Well, always with laparoscopy, with minimal access surgery in paediatrics, the concern is pneumoperitoneum. particularly with purging air from the lines and ensuring that we just have CO2 to reduce the incidence of air embolism, and being particularly careful about insufflation rates in paediatrics so as not to trigger a vasovagal response, which can be worse in younger children, and certainly in the context of having trauma as well. There are concerns about the accuracy or efficacy of minimal access surgery. Are you more likely to have missed injuries? Publications would suggest not in experienced minimal access surgeons' hands. However, it is a consideration. The duration of the procedure may well be longer, or it may not be, depending on what the willingness of the surgeon is to convert to open surgery should that be required. I'm going to leave my presentation there and move on to our next speaker. I believe Craig is going to follow up with some further discussion, if that's correct.
I'll try and speed things through because I want to leave some time for questions. I think we're the winners here as paediatric surgeons in the amount of stuff we have learnt from our adult surgical trauma colleague or surgery trauma colleagues. The one thing that we've perhaps given to you is the non-operative management of solid organ injury, and like any asymmetric relationship, we tend to trumpet the one thing that we've given rather than the millions of things that we've had coming back the other way, a little bit like when the Wallabies managed to beat the All Blacks at rugby. But there are some things that we as paediatric surgeons still struggle with. One of them is pancreatic trauma, particularly pancreatic transection. And when I saw that handlebar injury, the first thing that I started wondering about, Rebecca, was how was that child's pancreas? And we're not quite sure what to do with them. We are lucky in that peripancreatic fluid collections or even pseudocysts in children are perhaps a little bit more likely to resolve spontaneously than they are in adults. But we have typically less access to advanced ERCP. That's partly related to the frequency of the injury that we see, and partly also to the sizes of the patients that are developing these injuries. Pancreatic trauma, for example, only represents about 5% of the 8 to 12% of abdominal trauma patients who actually have an intra-abdominal injury. We are always keen to try and avoid ionizing radiation in children. And the reason for that is that there are studies, and this one's getting on a little bit now, but it was published in 2014 by Matthews, that showed that for every 1,400 CT scans you do in children or people under 20, you'll cause an additional cancer in the next 10 years. And that rate goes up by 16% with each subsequent scan that you might do. But it is a mainstay of our diagnostic algorithms in trauma. And we're always looking to try and move away from CT scanning if we can. And that, of course, brings up the vexatious issue of fast scanning in children. Children are different from adults, and they respond in a number of different ways. We have to remember that fast scanning was originally designed for the unstable patient that you're taking to theatre anyway, and you're just looking to see which chamber to open first, whether it's the abdomen or the chest or the heart. In children, in addition to the 5 spaces that we all know of where you can lose enough blood to cause hemorrhagic shock, there's a 6th space in children, and that's the head. Isolated head injury, as Warwick's already pointed out, is much more common in children than it is in adults. It's a leading cause of death. It's a marker of non-accidental injury. It's related to the way we restrain our children. And isolated head injury on its own is more common as a cause for hypotension in children than hemorrhagic shock. When you do fast scanning in children, the spaces that you see fluid are different. 95% of children that carry fluid inside their abdomen will do so in the pelvis. 35% only will have fluid in the right upper quadrant, and in the majority of those children, it's not in Morrison's pouch, it's off the tip of the liver. If you look at studies that have been performed, only the sensitivity of fast scanning is only 66% in some studies, and that's when performed by radiologists. If those scans are performed by ED physicians, it's anywhere between 28 and 52%. And maybe we're looking at this the wrong way, because in children, what we're actually trying to do is see if we can avoid ionizing radiation. So what we're primarily looking for are those children who we can safely, with serial observation, as Rebecca's pointed out, avoid a potential CT scan. And fast scanning at best has sensitivities and specificities in the 80s, with negative and positive predictive values that are not much greater than that, and in some studies less than that. So it's not a perfect rule in or rule out tool, but there are studies showing that you can use clinical algorithms to move yourself away from considering CT scanning in children. And this is one, looking at abdominal trauma that will require intervention. And if children have no seatbelt bruising, their GCS is normal. If they have no abdominal pain, vomiting, thoracic trauma, and their breath sounds are normal, then the negative predictive value for that child is 99.9% just on those criteria alone. You can do the same thing for thoracic trauma, and the negative predictive value for that child will be approaching 100%. That's for an injury per se. And if you want to restrict yourself to an injury that requires intervention, then that algorithm does have a negative predictive value of 100%. So those algorithms can perform better, perhaps, than fast scanning. We have to remember that in trauma, time is precious. And there are some large studies in a pediatric setting where fast scanning was used that have failed to show any change in outcomes with the use of fast scanning. The last thing I wanted to talk about, and it came up in one of the questions that was posted to us before we put this talk together, and thanks, Kate, for organising that. One is the trauma that other people are exposed to in treating children who are themselves victims of trauma. And I mean, not just the staff, but families as well. It seems to particularly impact upon nursing staff, many of whom are parents themselves, and particularly in adult facilities that aren't so used to seeing children with traumatic injuries. Medicine is one of the few professions where if the staff are suffering, the canary in the mine, if you will, that we encourage those canaries to become more resilient. Effectively, what we're doing is trying to find a more resilient canary. Maybe we need to look at our systems and processes to enable people to be able to deal with the vicarious trauma that comes from having children in a trauma room. We also need to think outside the box, and it's almost universal in pediatric trauma to allow parents to be present during the trauma resuscitation. It was first suggested in 1982 after a survey of family members of children who had died in Michigan. The majority of those family members said that they would have liked to have been there. And the concept was first published in 1987, just before I entered medical school. In my centre, most children are injured with their parents nearby. Their parents often witness the event, and then they arrive in hospital together, and it seems cruel to separate parents from their children at such a critical juncture of that child's life. A number of people have voiced concerns, and the ones that are most commonly voiced are the psychological trauma that the family members might experience in witnessing a resuscitation, that parents might get in the way, that they may subsequently sue, or that the team itself may suffer in the level of its performance anxiety, if you will. And none of those are borne out in studies that are performed. The single exception to that statement is parents getting in the way. And the only example that I can find where that actually happened wasn't in genuine trauma. It was in a mock trauma where they had actors paid actors to play the role of parents who became quite histrionic, as actors are wont to do during the resuscitation. But in real settings where parents really are in the trauma room, there's no evidence that they get in the way. There's no evidence that they then sue. If you ask parents themselves, parents that have been in those situations, they think that it helps to bring comfort to the child during the resuscitation, particularly if the child's still conscious. It helps the parents adjust to the loss in situations where the child subsequently dies, when compared to parents who weren't present for resuscitation. In that, parents have been able to see that all staff are geared towards treating those children. So it's something to consider, but I accept that it's very, very challenging, particularly in settings where people are off their ground. Similarly, if you're making decisions about whether to scan or not scan children, and you're not used to the sorts of decision-making rules that you're confronted with, there's always an incentive to default to what you would normally do. And I think that's a fair and a legitimate thing, because it's very different for me treating pediatric trauma than it is for adult trauma surgeons treating pediatric trauma. But one of the things that we might be able to do is be on the end of the phone to have a conversation. And we're in Queensland, we've got thousands of miles between us and some of the children that we treat. And on a number of occasions, we've actually either been phoned or video linked into the trauma room during the resuscitation to provide a second opinion or some advice during the trauma. So that was the last two things that I wanted to say, and hopefully, Kate, you'll forgive us for going over time and we might be able to answer some questions.
I'm going to hand over to Jeremy Stew now to get started with the questions. Thank you very much for all of those presentations. Jeremy, over to you.
Yeah, I just wanted to echo that. I think that's fantastic. I mean, as an adult trauma surgeon, it's always interesting to hear the differences, and we're pretty lucky in Sydney that I've got my colleague Sounderpan just down the hallway, and so we've got that mix, but they're very separate. But I guess what I wanted to start off with is that I think Craig opened with the statement that he's a frustrated pediatric trauma surgeon. And I think that this also relates to some of the adult issues that we have in terms of the actual trauma surgical skills that are required. And that includes the operative technical skills, but also the operative decision-making, because it's very easy in those, like that aren't very sick. But when you have time-dependent, very sick patients, you need those skills. So I actually was going to just maybe start off with James Hamill from New Zealand about what are your thoughts about how do you maintain, how do you ensure that pediatric surgeons, and then as a secondary thing, adult surgeons who may have to look after pediatric patients, how do you ensure that they have the adequate skills, both operatively as well as the decision-making to operate and intervene?
Thanks, Jeremy. Hey, the question's the same question as posed to a lot of adult trauma surgeons. And because, as you know, the amount of adult trauma surgery has decreased remarkably since the advent of non-operative management and interventional radiology, etc. And the answer in terms of the operative skills is to have a specialty in which you're doing operations which use that prerequisite skill set. The other side of the coin, in pediatric surgeries, we often work in small units, like there's 6 surgeons in our unit, there's 5 on the roster, and this is similar to other units around Australasia. And there you're really reliant on your colleagues because none of us are going to be on call one-on-one. And then thirdly, we're reliant on our adult colleagues. I mean, we're very lucky, like a lot of hospitals, I guess, where immediately adjacent, just like in Westmead and down the corridor, to an adult hospital. So if I have a crashingly horrible liver injury, I'll be on the phone to our liver surgeon, adult one that is. Yeah. The other way, you sort of end up feeling a little bit of a fraud as a pediatric trauma surgeon and hardly ever doing an operation, which is not fair, but you do have this sort of imposter type syndrome, or a lot of us do, and it helps just to teach on courses. I mean, so those of us who like teach on DSTC, you just sort of feel like you're keeping your hand in a wee bit by teaching other people.
Right. And did the others on the panel have any thoughts about that? Any contributions about that skill? The skill maintenance and things?
I agree completely with what James has just said. There is a degree of imposter syndrome. I hear that and I share that, James. There's also a utility, I think, in calling an adult colleague and working on something together. We've been in similar situations and called the pancreas guys or the liver guys. We're lucky to have a good relationship with those guys for some of the more complex things that we don't see often enough to choose to do ourselves. And having two consultant surgeons who are both slightly off their ground, one by virtue of size and the other by virtue of complexity, that the combo deal is stronger than the sum of the two parts, I think. I'm privileged and lucky. I get more trauma experience each year at the DSTC course than I do in the entirety of the rest of the year. It always seems to me that every time I've done the DSTC, I step back on call and get some hideous trauma, some child impaling themselves on a pool fence or something like that. So I do wonder about karma smiling down on me and thinking, just you wait.
I think we should never judge, and I don't think we do judge surgeons by how often they cut, by the decisions they make. I think that resonates strongly with all of us, and the non-operative management is something that paediatric surgeons brought to trauma, although it's now widely adopted across both paediatric and adult faculties. I also think that it's great to be engaged in adult trauma, and to do so educationally is brilliant, but also to be proud of the generality that we bring to our surgical craft. Pediatric surgeons are routinely entering chests and abdomens, whereas many adult surgeons are routinely entering one or other of those cavities. And we have the privilege as pediatric surgeons to have a skill base which quite often goes into either of them. So that's an advantage for us. But I think that maintaining strong relationships, and people can stay in ivory towers and they will rot there. But the more that we engage with the broader system, the better. So being a part of a bigger system and being an honest and intellectually honest part of that is really important as well.
I'd agree with that as well, for my 2 cents worth, that the collaboration and transferable skills are some of the really important hallmarks of being a paediatric trauma surgeon. And that transfer of skills, probably most commonly I'm doing a damage control laparotomy in a neonate, not in an older child from trauma. But those skills are transferable, and managing the grossly unwell child who's ventilated in an intensive care setting. And it is a very transferable skill.
And Noah, did you have any comments, particularly about because you did mention about the difficulties in insertion in the resus room for technical skills. So did you have any comments on how do you ensure that that these skills are maintained or are there in the providers?
Yeah, so we're starting a credentialing process, and it's timely that you ask that question when we're talking about transferring skills between adults and pediatrics, because that's exactly what we're doing in Dublin. So we do a lot of work with the Mater Hospital in Dublin, who have been designated as one of the new major trauma centres for adults in Ireland, and we're starting a joint credentialing process for thoracotomy, chest drain insertion, and then early next year for resuscitative thoracotomy. Given our low volume of paediatric trauma, consistent with worldwide data, we actually do a lot of work with our adult colleagues. We do joint simulations, joint skill stations and procedure stations, and as I've said, that credentialing process is going to be done on a joint basis, so that the skills are largely transferable between adults and paediatrics, and we do huge amounts of work with them as the new designated major trauma centre.
Thank you. Just a little bit of a secret, just don't tell anybody though, but more and more of adult trauma is becoming non-operative as well. So just because, as Warwick said, just because we're not in the operating room doesn't mean that everybody that's involved in the care of these patients isn't making a significant difference to the outcome. And I think that's what it boils down to. It's the decision making and a timely decision making that influences the outcome for these kids. Time is our enemy, unfortunately, and it has just ticked over 7:30 at least here in Melbourne. I do thank those of you, particularly Nuala and James, who are in a very different part of the world where it's much earlier or later. Thank you very much to everybody for all of your expert input and your pearls of wisdom. I think it's a space where I'm certainly looking forward to doing far more collaboration with paediatrics and seeing the two branches of trauma dovetail in together more and more. There have been a couple of questions that have come through on the chat. So what I will do is I will flick them to the panel, and then when we post a recording of this, once it's all been edited, we can include them as well, some commentary around those questions in that as well. So once again, thank you very, very much, everyone, for your input. Thank you very much to our audience online. And please, if you could fill in the post-session questionnaire survey, that would be much appreciated. We'll see you in December. I'm almost about to confirm our keynote speaker, but it will be on retroperitoneal injury, which was another popular, difficult, challenging area of trauma surgery that is often requested in the feedback that we get. So be safe, everybody. Keep COVID safe, and we will see you in a couple of months. Thanks a lot. Bye.
Thank you, everyone.